Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with the director of the Yale Cancer Center, Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about head and neck cancer with Dr. Barbara Burtness. Dr. Burtness is the Anthony N. Brady Professor of Medicine and Medical Oncology at the Yale School of Medicine. Here's Dr. Weiner.
I'd first like to just ask how you wound up doing what you do. I don't think we have to take this back to age 10, but I did actually know you many years ago when you were doing some of your training, and I was thrilled when you decided to become a medical oncologist. But it's been a little bit of a roundabout path to head and neck cancer where you've been so successful. So tell us a little bit about that journey.
Happy to. So, I picked medical oncology partly because I loved internal medicine so much. And in medical oncology, between the diagnostic challenges, the complications that the cancers can cause, the complications of treatments, you are always the person's whole doctor. You have to understand all of their systems. So I really liked that. And when I first became involved with clinical research in medical oncology, I was in some years ago when people were less specialized than they are now, I was taking care of predominantly patients with breast and GI cancers. And in those cancers, as in many others, we needed new drugs. And I was lucky enough to be involved in the first clinical trial of one of the first antibodies that targeted growth factor receptors on cancer cells. This was something called cetuximab. And in the course of enrolling patients in that trial and treating patients in that trial, we had some patients with head and neck cancer who had great responses. And I took the concept of testing this as a first-line treatment for head and neck cancer to one of the cooperative groups, ran a phase 3, or one of our larger type clinical trials with that drug in head and neck cancer, and just became more and more fascinated by this disease, which is very, very complicated in an anatomic way, very complicated in the ways that it arises, complicated in the ways that treatment resistant arises. And yet, I think one of the cancers where we have seen the greatest successes in recent years through better understanding of the different biological classes, advances in radiation, advances in surgery, and advances with immunotherapy. So it's been a wonderful thing to be part of.
So I think people are a little less familiar with head and neck cancer than they are with, for example, breast cancer or colon cancer or prostate cancer. So let me just ask you a few general questions. So the name itself is a slightly funny name when we say head and neck cancer. And, we're not talking about brain tumors, so it's not that part of the head. But what are the tumors that fall within this category of head and neck cancers?
Yes, that's a great question. And I think something that when patients are looking for the sign on the door, head and neck clinic, they're wondering about. So I think it started with those cancers that were operated on by the otolaryngologists or ENT surgeons who call themselves head and neck cancer surgeons. And so the overwhelming majority of these are tumors that arise in the membranes that line the inside of the nose, the mouth, and the throat. And maybe 95% of the cancers that we see, those are referred to as head and neck squamous cell carcinomas. And there are two predominant types, one that arises because of a viral exposure and another that arises mostly from tobacco and alcohol exposure. There are some others. There are some unusual cancers that arise in salivary glands and other small structures that are inside the same tissues of the head and neck area. And we also see some skin cancers that arise on the the face and the scalp because they have drainage patterns and special treatment requirements that are somewhat similar to other head and neck cancers.
And how common are these cancers? So if you just lump them all together, these cancers that arise in the lining of the nasal and oral cavities and throat, how many cases are we talking about in the United States each year?
Probably about 65,000.
So that's a fairly large number.
Yes, it is. And there are many other patients who have what we call premalignant lesions. So these are small growths on the tongue or the floor of the mouth or the inside of the cheek that are caught before they become cancers. And there's another substantial number of patients who have those.
And you mentioned before about the complicated anatomy of these cancers. It is complicated. I mean, I will tell you that in medical school, the last thing I wanted to learn were all the intricacies of the anatomy of the throat and the nose and what have you. It lots of very little structures, hard to see. You need special devices to be able to look at many of these areas. How does that affect all of your treatment planning and diagnosis and what have you?
Yeah, in a lot of ways. So the first thing is that because two structures that are only a couple of millimeters apart from each other are really different parts of the throat or the tongue or the mouth, the drainage patterns and the patterns of spread of these tumors are very specific to the actual subsite of the head and neck where they arise. So it's very important to have diagnostic accuracy about this because you need to understand which are the lymph nodes that you're worried the cancer might have gone to that you need to include in your treatment approach. So that's the first thing. The second thing is that any toxicity from treatment, swelling from radiation or damage to a nerve from surgery, could arise because the normal structure is so close. These very important normal structures can be very close to tumors. And then the third thing is this is the part of our bodies that we most rely on for interacting with other people. So smiling and speaking and having a meal with your friends and your family, these are all things where you want your tongue and your voice box to be working as normally as possible. So a big emphasis for us in treating people with head and neck cancer is not only picking a treatment that's highly likely to be curative, but also finding a treatment that's going to do the best job possible of preserving function so that people can speak in their jobs and their social lives, so that people can eat normally in front of other people. And so there's been a huge part of the progress over the past couple of decades has been advances in conformal radiation and robotic surgery and reconstruction that allow us to get the cancers and yet preserve patients' function, so that the old story with feeding tubes and so forth is much less common than it used to be.
And by conformal radiation, you're referring to radiation that is much more molded to the area that needs to be treated to effectively treat the tumor.
Correct. We want we absolutely want the dose that's required to kill the cancer to be delivered to the area where the cancer is. But we would prefer to not have to deliver that to the spinal cord or adjacent normal structures. And I think this is one of the reasons that radiation for the head and neck cancer has become as specialized as it has, because a radiation oncologist needs to be doing a fair volume of head and neck radiation sort of week in and week out to accomplish this pretty technically demanding treatment planning.
So you just touched on radiation oncologists. You're a medical oncologist, but I happen to know the team is way bigger. And maybe you could comment on the need for these, I think, almost massive multidisciplinary teams that involve both doctors and many people who care for patients who may themselves not be medical doctors.
Absolutely. So the first thing I'll say is the surgeons. So these are all individuals who have fellowship training in head and neck cancer surgery. And they are joined by surgical specialists who focus on vocal cords, on reconstruction, including the ability to reimplant nerves to return function to a person with paralysis of the facial nerve. The swallowing rehabilitation is a huge issue for us. So we want patients to be able to enjoy their food and to do so safely without any risk of developing pneumonia as a complication. So we have a great team of speech language pathologists who works with patients even before radiation. So we call it prehabilitation, getting started with the exercises before the treatment even starts. Nutritionists, audiologists, social workers, and then in the treatment teams where we deliver chemotherapy and radiation, the nurses and the infusion room nurses and the radiation technologists who deliver this therapy are extremely familiar with the treatment paradigms for head and neck cancer, the complications that arise. And there's a lot of evidence to say that being treated by a team like that, where there's seamless integration, there's great communication, and there's high familiarity with these complex treatments, makes a big difference for getting patients through on time to full dose and with minimal complications.
And you may have said this and I may have missed it, and I know if for any reason you didn't say it, it's top of mind for you. Dietitians and the whole area.
Yeah, I said nutritionist, but absolutely.
You said nutritionist, yeah. But maybe you could speak for a minute about how complicated all of this gets, because sometimes when people are getting treatment, their ability to actually get in adequate intake really declines pretty precipitously.
Yeah. So even the tumor itself, when patients present with head and neck cancer, sometimes weight loss is one of the initial symptoms. But certainly the treatments with surgery that's happened in the throat or radiation that's aimed at the throat can make it either difficult to swallow or painful to swallow. And we have whole treatment plans that we use for managing that kind of throat pain to allow people to return to swallowing solid food as quickly as they can. But we really need to keep the overall number of calories up. And so we work with liquid nutrition, with soft diets, and with medical regimens that help reduce the burning in the throat.
Yeah, no, this is complicated business. And of course, the more we can support people during treatment, the better they're going to do afterwards, the better they'll tolerate the treatment, and the more rapidly they will recover. So we're going to have to take a break for just a minute. When we come back, we'll talk about the causes of head and neck cancer, which you've already alluded to. We'll talk a little bit more about some of the advances in treatment and where the field is going. So to our listeners, hold on just a minute.
Funding for Yale Cancer Answers comes from Smilo Cancer Hospital, offering spiritual care to patients and caregivers seeking peace in the midst of their cancer journey, while respecting the philosophies, spiritualities, and religions of patients and caregivers. SmiloCancerHospital.org. Breast cancer is one of the most common cancers in women. In Connecticut alone, approximately 3,500 women will be diagnosed with breast cancer this year. But there is hope thanks to earlier detection, non-invasive treatments, and the development of novel therapies to fight breast cancer. Women should schedule a baseline mammogram beginning at age 40 or earlier if they have risk factors associated with the disease. With screening, early detection, and a healthy lifestyle, breast cancer can be defeated. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilo Cancer Hospital, to make innovative new treatments available to patients. Digital breast tomosynthesis, or 3D mammography, is also transforming breast cancer screening by significantly reducing unnecessary procedures while picking up more cancers. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
This is Eric Weiner once again. I'm here with Yale Cancer Answers, joined by my guest, Dr. Barbara Burtness, Anthony N. Brady Professor of Medicine in Medical Oncology at Yale School of Medicine. And we're talking tonight about head and neck cancers, and want to return to the topic of what causes these cancers, because I think we know more about what causes these cancers than what we know in terms of causation about a lot of cancers. So do you want to first touch on the behavioral causes, and then we'll move on to the viral causes?
Sure. Yeah. So in the United States, the behavioral causes of head and neck cancer are predominantly linked to tobacco and alcohol usage. And there's an interesting interaction, so that a person who smokes and drinks alcohol is more likely to get head and neck cancer than a person who smokes the same amount of cigarettes but doesn't use alcohol. And this kind of head and neck cancer has been recognized for a long time. It has historically been a little bit more resistant to chemotherapy and radiation, and which is not to say that we don't cure the majority of patients who have this, but the fact that this is the first kind of head and neck cancer that was studied led to the use of pretty high doses of radiation for head and neck cancer. And when we talk a little bit about the other kind of head and neck cancer, which may be curable with lower doses of radiation, that was an interesting challenge. How do you figure out how to use a little bit less therapy than you're used to using? We tend to see that as if people successfully quit smoking, their risk of developing a head and neck cancer will go down over time. And we also see that for patients who continue to smoke during the treatment is less effective than if they're able to quit smoking, even if they quit the morning that the treatment starts.
And what's the reason for that? Do we understand?
We don't completely understand it. However, we do know that there's not as much oxygen in head and neck tumors. We spoke before about how they arise in pretty small compartments, but they themselves can be, a few centimeters with sort of iffy blood supply. And there are often areas in tumors that have low oxygen content, and those low oxygen areas are less responsive to radiation. So it may be that just the blood vessel spasm that arises from the nicotine worsens that hypoxia.
Wow. Okay. That is not something that I knew by any means. And I'm just guessing that patients who smoke a great deal and sometimes drink a great deal are also patients who are probably less likely to be diagnosed at an early stage. So many of these patients have relatively advanced head and neck cancer when they're first diagnosed. Is that correct?
There certainly are patients who come in with large tumors that perhaps could have been diagnosed earlier. There are patients who are regular drinkers, but also get regular dental care. And,
Yep.
A good dentist may pick up a small lesion on the margin of the tongue and will be able to take it out before it's even an invasive cancer. So I think there's a mix there.
Yeah. No. I'm sure there is. And what about the viral causes? And here it's a particular virus.
So in the United States and in Northern Europe, there's been a steady increase, about 3% per year, since the late 1960s, of tumors in the tonsil and the base of the tongue, that is to say at the back of the throat, caused by human papillomavirus. And this is a virus, a human virus, obviously, with about 200 types. And among those types, there are 5 or 6 that have a strong propensity to lead to cancer. This is the same type of virus that leads to cervical cancer, which was a very common cancer of women a few generations ago. And the thing that's different about tonsil cancer is that we don't have a pap smear the way we have a pap smear for cervical cancer. It's also the case that these tumors tend to be very, it's not always the case, but it's often a very small primary tumor, sometimes even buried deep into tonsillar tissue and not on the surface. It's one of the reasons a pap smear has been hard to develop. And so many patients present with these types of head and neck cancers just with a painless lump in the neck. And when this epidemic was first starting to be common, radiologists were often, the tumor was small and they'd see a cystic lesion in the neck and not so certain that it was as cancer. I think over the past 20 years, that problem has gone away and these cancers are widely understood now. But so the first presentation may often be a painless lump in the neck.
And that lump in the neck is a lymph node.
It's a lymph node. It's got a lot of fluid in it, but some tumor. This is a kind of cancer that we think will go away because of the human papillomavirus vaccines that are now available. These are recommended for girls and boys, men and women up to the age of about 45. And the expectation is that as vaccine uptake increases and vaccinated patients enter the sort of the age group where these tumors are seen, that the frequency of these kinds of cancers will go down. As I should say, has the frequency of the tobacco-associated cancers are a little bit less common than they used to be as more and more Americans have quit smoking. In other parts of the world, there's another virus that causes head and neck cancer, and that's the Epstein-Barr virus. We think of it here as being associated with mono, but in many parts of the world, for example, the Pearl River Basin in China, this is associated with nasopharynx cancer. And so this is another virally associated cancer that arises in lymph tissues within the mucosal structures of the back of the nose.
And do we see that with any frequency in the U.S.?
We see it in the U.S. for two reasons. The first is people who are immigrants from those parts of the world. And the second is that in the United States, in areas where historically there have been crowded housing, poor housing, there are some hotspots. So we do have a little bit of it in New Haven still.
So let's talk about what I think are some of the dramatic advances in head and neck cancer. And maybe before we get to the medical treatments, it seems that surgery has improved, maybe partially because of other treatments that are effective, but the surgical approach is far more specific, less likely to leave people quite as debilitated.
That's for sure true. So first of all, for these small tonsil cancers, base of tongue cancers, there's now the ability to do surgery through the mouth without having to split open the jaw. And this can either be done with a robot, which is the approach that my colleagues here at Yale have favored. And there's also there's a small number of surgeons who use a laser to do this. But the ability to do transoral surgery under magnification in the back of the throat has been a huge step forward. Then we have the ability to do reconstruction with tissue flaps and bone grafts from the person's leg usually, and these lead to extremely good cosmetic results. They have very high success rates. So that's been a huge breakthrough. And then I mentioned facial reanimation for patients who've had facial nerve injury. So the surgery has come many, many miles.
Yeah, no, I mean, it's really pretty dramatic if you compare today to 30 years ago. Yeah. It's really quite remarkable. And why don't we already touched on more specific radiation approaches, but what about medical therapy or systemic therapy, chemotherapy plus? So chemotherapy plus targeted therapy, chemotherapy plus immunotherapy. And you, I happen to know, have been involved in many of those clinical trials that have led to pretty dramatic advances in head and neck cancer.
Yeah, we've seen great progress. The most recent big advance has been the use of immunotherapy. And so this was first pioneered in melanoma, kidney cancer, lung cancer, actually by many of my colleagues here. And it was obvious that there would be some patients who had the markers for immunotherapy. And when we first brought this to patients with head and neck cancer, there were some unknowns. Certainly I mentioned before sort of the blood flow issues in some head and neck tumors. The amount of the target for immunotherapy was lower. There were more tumors where immune cells didn't seem to get into the tumors. And so we've evolved a strategy where we can look at the tumor and measure sort of the target of the immunotherapy, a protein called PD-L1. And for patients where that's high, have good reliance on immunotherapy. And then for some other patients want to incorporate immunotherapy together with chemotherapy. And so we have known for a couple of years now that if you use that for patients with recurrent disease or metastatic disease as your first treatment, you will have a significant improvement in how those patients fare. And very recently we have heard, although we haven't fully seen the data yet, that a large trial looking at the use of immunotherapy before surgery is showing that is almost independent of how much it shrinks the tumor and how much it affects what surgery you're able to do. But the early introduction of immunotherapy seems to have a very favorable effect on how patients fare. And that makes sense because I've sort of touched on this a couple of times, but all of our standard therapies in head and neck cancer have to do with treating the lymph nodes that we think the tumor might spread to. But those lymph nodes might also be the seat of the immune response. And so being able to leverage that immune response early might be a huge step forward. And we anticipate that there will be much more first-line pre-surgical use of immunotherapy in the future.
And is that PD-L1 protein important in that setting as well?
Not to the extent that we have seen the data. However, the majority of head and neck cancer patients express some. Yeah. And so I think there'll be some interesting detail to parse there.
Well, and you probably know that in so-called triple-negative breast cancer, that PD-L1 is very important in patients who have advanced disease, and in patients with earlier stage disease, it doesn't seem to matter as much. So it's really recapitulating, the same data. It's interesting. And what about the HPV-associated tumors, where you have other treatments as well? Does immunotherapy work there?
Immunotherapy does work there. We thought that it was going to work way better than in HPV-negative cancer because we thought, well, the virus is an obvious immune target. But it turns out that the human body has ways of evading the immune system that privilege those virally infected cells. And so we are very interested in our research program here in strategies to sort of re-expose the immune targets in HPV-positive cancers. And we're doing that in clinical trials in the preoperative setting. There are also trials that we're involved with that look at incorporating a vaccine against HPV together with immunotherapy. So we do have some specific immunotherapy approaches for those patients.
Dr. Barbara Burtness is the Anthony N. Brady Professor of Medicine and Medical Oncology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.